Welcome back. Today's video will be a little bit of a longer video. We're going to talk about what genetic testing means in the settings of obstetrics, gynecology, and fertility. We had this discussion in small videos before, but I think it's best to have it in one longer video to explain the different words and terms that you might hear when you're talking to your physician or reading online or something like that. The word genetic testing is an all-inclusive word or all-inclusive term that means a lot of things underneath it. It's kind of similar to when you say, I'm going to do a blood test. Many actually use it just to say, I got tested, the blood test, whatever. But in medicine, the blood test, they take blood from your vein, yes. But then what did they test in the blood? Did you have a blood test for sugar to check diabetes? Did you have a blood test for cholesterol and triglycerides to check for heart disease risk? Did you check your kidney function tests? Did you check your liver function tests? Did you check infections or hepatitis immunity or things like that? All these are blood tests. And there is a lot of other blood tests that can be done. So while we talk socially, we say, I had a blood test done. Medically, the answer relies into which blood test did you do. So many times we tell our patients, you need to do a blood test to check whatever. They say, but I just did a blood test last week with my family doctor, for example. Then we explain to them that, yes, family doctor might have checked, for example, your hepatitis immunity or your diabetes or your kidney function, but we need to check your hormones or the egg function or something like that. So they're all blood tests. Now, when we check genetic testing, the test done will depend on the circumstance of the testing. Why did we do the testing? What was the reason you did the testing? So, congratulations, you're pregnant. You want to do genetic testing, so to speak, to check that the baby is healthy. In most jurisdictions and most places in the world now, there are these tests that can be done. In Canada, in Ontario, there are basically two types of tests that can be done. The first one is enhanced first trimester screening, EFTS. This is typically done for all women who are pregnant. It's covered by the provincial programs for universal, everyone who's younger than 40. It's a good test. It's a good negative test. So if your tests come back negative screen, you're likely really negative. If your test comes back positive screen, then you need to do the other test, which is the NIPT testing. What is the first one? What is the EFTS test? It's two components. You have to do an ultrasound around 12 to 13 weeks, associated with a blood test at the same time. We look for a few things: the measurement of the neck of the baby, certain plasma-associated protein, estriol, HCG, whatever, some 4 or 5 chemicals and hormones in your blood. We also include your weight, your ethnicity, your smoking status, diabetes, or if you're taking insulin. And then all this information is fed into a computer system that says, you're okay, you're low risk, or we think you need to do the other test. Don't freak out if you test or if you screen positive with EFTS. When you do the NIPT, the second level test, a lot of people are negative because how the statistics work, where we might scare a little bit more few patients to do the second test who are normal, better than reassuring someone who was carrying a baby with issues. What issues do we look for? The measurement of the neck of the baby looks for swelling, usually associated with cystic hygroma, swelling in the neck of the baby, that may be associated with some chromosomal problems. We also check 5 of the chromosomes that are most commonly affected with genetic problems: chromosome 21, 18, 13, and the X and Y chromosomes. It doesn't tell you boy or girl. It's usually, as we said, it gives you a statistical screening, positive or negative. The other test, NIPT, that usually is done reflex, like after you screen positive with EFTS, would be a simple blood test where we actually check for the 5 chromosomes, X and Y, and then 21, 18, and 13. And this will tell us if we have normal copies or if we have an abnormal number of copies, and they will tell us what the problem is. Now, recently, I saw people talking more about the NIPT and how they want to do it when it's not indicated for them. NIPT is indicated if you have 2 babies, twins, if you're older than 40, if you screen positive with EFTS, if you had a baby with an issue in a previous pregnancy, or if there are concerning information on ultrasound or history or something. But many people with none of these things, they still want to do it. It is $500, $600 average. I'm not sure exactly how much, but you may be paying money for no real indication. It's not better or worse. It's like, if it was the best thing, the government would have suggested that we do it for everyone anyway. But cost effectively, the way we're doing EFTS, then NIPT makes more sense. Paying out of pocket, you can do anything you want to do, but don't do it because your friends did it and you feel you're missing out and you need to do the same thing. You're okay not doing it. Some people do it only to know if it's boy or girl, the pregnancy. I will not say anything about that. It's a personal preference. But if you wait until you're 18 weeks, 19 weeks, and you do an ultrasound, the ultrasound will tell you if you're carrying a boy or a girl. Your decision. But people who want to reassure that my baby is absolutely healthy, we tell them there's no answer to that question. We might have normal screening tests and we still have issues because there is developmental things that might occur. To note here, there is no test for autism yet. So if this test reassures you that the 5 chromosomes are okay, this doesn't say or yes or no about autism. There is NIPT extended where we check all 24 chromosomes. If you really want to make sure everything is okay, you can think about doing that. It's not indicated routinely because the other remaining chromosomes, they're very rare to have issues. And usually if they have issues, they show on ultrasounds. But again, talk to your doctor about what you want to do, and they will explain to you the benefits of each test and the indications and the value of how much money you will pay for how much actual reassurance will we get, and then you reach a decision of what you want to do. So this is the pregnancy routine screening part. Sometimes with pregnancy issues, if you go to maternal-fetal medicine physicians, sometimes they do something called CVS, where they take a chorionic villus sampling, a small piece from the placenta next to the baby, to check if we have chromosomal problems or not. Typically, it's done vaginally. Rarely, it's done through your tummy for easier access vaginally. Rarely, the other option that you might need is called amnio, maybe 16 to 18 weeks, where they go through the belly, through your tummy, with a long needle to get some fluid from around the baby for genetic testing. Usually this is done if we are talking about possible termination of our pregnancy and we really want to make sure that the baby really has a problem or what there is questions whether the diagnosis was correct or not. This is beyond our discussion. If you reach that stage, the maternal-fetal medicine physicians will discuss this with you at greater detail for sure. So this is the group of genetic testing that we would do for pregnant women. Now, couples who are not pregnant may do some other tests, genetic tests. The first set of them are, there are new, recently, we're recording in 2025 now, right? So recently, 1 or 2 years ago, some American companies started producing genetic screening panels. If you have high risk of heart disease in your family, they do genetic testing for high risk cardiac diseases or neurology diseases or risk for certain types of cancers. It's a blood test. It's on your own expense. It's not mainstream yet. And then when you do these panels, they tell you if you're low risk or high risk for this type of cancer or that type of cancer because you're carrying these genes, and you have a discussion with your physician about health care choices, lifestyle choices, and maybe screening options that you need to do. This is a little bit beyond our discussion. It's a long story that you need to have with your physician who's talking to you about that. But in the field of obstetrics and gynecology and fertility, there is genetic testing to know if we are carrying a certain one type of disease. The example about that, bad example, but let us say yellow ear disease. This is a fictional disease. There is nothing with that name. But let us say someone is worried that they're carrying yellow ear disease. Someone in their family had that thing. So we do a blood test and we ask the lab, the genetics lab, to check for the yellow ear disease. Let's say the gene is called ABC123. So they check for the gene ABC123. They tell us, yes, you carry this disease, or no, you're not carrying this disease. Now, usually, if you have a yellow ear, then we know you have the disease. And then if you do genetic testing, usually the test will come back positive, whether it's autosomal dominant or recessive, details about how you're carrying the disease. But we usually talk about recessive diseases where I am a healthy person, but I may be carrying one part, one half of the gene. If my partner carries the other half of the gene, the baby, when it forms, it might be carrying the disease, the two halves. So the baby will be born with the yellow ear disease. So people who have this disease in their family or for ethnic reasons, we know they're at a higher risk. For example, Caucasians maybe carry more cystic fibrosis, maybe Asians carry more hereditary hearing loss. Africans carry more, for example, spherocytosis or sickle cell or something like that. So depending on the geographic area, or if we know a family member has a disease, we do the genetic testing, the carrier genetic testing, to check if I'm a carrier, my partner is carrying the same disease or not. This comes more handy as well when people are using donor material. So we want to make sure that the sperm and the egg are not carrying the same disease. Otherwise, the baby might be born with that disease that both sperm and egg are actually carrying. So this is called CGT, carrier genetic testing. And depending on the disease, depending on the issue, if we come back positive, we ask the genetics lab to create a probe for us, a key, for example, and tell them, can you check if you can detect this ABC123 disease in the baby, the yellow ear disease in the baby? They take their time and then they say, yes, we can do that. Do your IVF, send us baby samples. So we do IVF, test tube babies. When the embryo is in our hand in the embryology lab, we take a specimen from the placenta around the baby and send it to the genetics lab and tell them, can you please check for this disease that you had a probe? I use the example that it's like a key and they try to open the embryos. The embryos that click open are the babies that have disease. We will not transfer them. But those that are normal, healthy, even if they're carrying one half of the gene, not the other half, we can still get pregnant with them. The baby will be a carrier like one of the parents, but it will not have the disease itself. This is called PGTM, preconceptional genetic testing. Now, associated with that is a small story that we do in most cases of IVF, which is PGTA, prenatal genetic testing for aneuploidy. We're counting the chromosomes of the babies, the embryos, before we put them back inside the uterus. We do our IVF, and when the baby are with us in the lab, we take samples from the placenta, and then we send them to the genetics lab, and we tell them, can you please count the chromosomes and tell us how many chromosomes there are in these embryos? Most of us carry a complete set of 46 chromosomes. One of them, or two of them are X and Y for male and female. The sperm carries 23 chromosomes. The eggs carry 23 chromosomes. When they unite, they make 46 again. Sometimes when they're reuniting, they make an error. So then the total number is not 46. Sometimes after they unite and the egg starts dividing and making a whole human being from the one fertilized cell, the egg makes an error, and then we start having an abnormal number of chromosomes. So the abnormal number can be just one extra chromosome, for example, 47 with an extra chromosome 21, trisomy 21. Then we have those children that have a special way where they look, they might have preconditioned higher risk for certain diseases. They might be socially or developmentally at a disadvantage at certain situations. We can talk about this later. There are other conditions where, for example, trisomy 18 or 13, where the baby doesn't usually continue developing until it becomes a child. Usually we lose the baby during pregnancy or early after birth. So these tests can be done to confirm which babies are normal chromosomal numbers, and then which ones we will use to put inside the uterus and try to get pregnant. There is a lot of debate in the fertility field of whether we should do this for everyone or not. It's a long discussion. The older we are, the more likely that the eggs might make mistakes while they are dividing. So maybe if we only have a certain number of eggs, whether it's worth checking them or just doing a transfer. Or if we have a big number of eggs, sometimes women are concerned about their chances of getting pregnant. With 1 or 2 or 3 miscarriages, this becomes too emotionally challenging for them. With trying many times to get pregnant and not actually getting pregnant after a transfer, this is a little bit too emotionally difficult for most women. So does it make sense then to do genetic testing so that we reduce the number of failed transfers or reduce the number of miscarriages by just eliminating the abnormal embryos that we know will not get them pregnant or might get them pregnant with a baby with problems? This is a long discussion that we strongly urge you to have with your healthcare provider because the choices are not straightforward. Again, people listen to social media a lot, people read online a lot. Sometimes the decision making is a little bit more difficult. Sometimes there is a little bit more details that you need to have from first-hand healthcare provider to help you make the proper and correct decision that suits your condition. So this has been a long video. Thank you for staying that long. I hope it was any useful. I don't think this is comprehensive enough. This is just scratching the surface of a very deep and complicated story. Talk to your healthcare provider about more details. And thank you for watching.